All righty. Well, welcome everyone to the final of this early fall series of Delaware Mini Medical School. It's been wonderful to be working with our partners from Bay Health, and we're going to be wrapping up on a subject that is, for all sorts of reasons, near and dear to me personally, and really looking forward to it. Let me go through the traditional slides here. So we are streaming live on YouTube. I will drop that direct link into the chat for you. If you have any problem with the Zoom client, you can always go watch it on YouTube. Just make sure to let Nicole Sabine and or I know that that's how you watched. DelawareMiniMed.org in partnership with Sussex Coalition, which is Sussex County Health Coalition. Just to remind for the last time that there is a Pathway to Physician series that's going to be offered in Newcastle, Kent, and Sussex by the Delaware Institute for Medical Education and Research, called DIMER, and then the Delaware Health Science Alliance. There's the link there. I will also drop that in the chat. Housekeeping tips, as always, to remind, this is a webinar, not a meeting. You can't see each other, and we can't see you. You can see us. Please use the Q&A feature, not the raised hands, except for one person whose hand raises because gesture recognition is, yep, there you go. Hi, Valerie. Anyway, yeah, so Q&A. Remember, don't ask questions of a personal nature or a family nature. We need to be very careful with privacy. All questions will be answered, housekeeping ones by Christy or myself, most all of the clinical ones by the presenters. And finally, to remind you, you need to stay through the entire presentation, but when the presentation's over and we get to Q&A, at that point you can leave. At this point, I'm going to turn it over to Christy Handley, my fearless co-host, to introduce this evening's speakers. Christy?
Great, thanks, Tim. And yes, I am with the Sussex County Health Coalition, and many of you have heard our spiel before, but I do want to remind you of an event that is coming on November 14th. It's a Friday at the Calvary Church in Dover on Route 10. We have Tara Connor and Carrie Bates joining us. One is an Olympic gold medalist. That is Carrie Bates. She'll be joining us. And Tara Connor, who is a former Miss USA. They're both going to be talking to us about their struggles with substance use disorder. So please register with us, and I'll put that information in the chat. And Tim, you can go to the next slide. So I'd like to introduce tonight's guests. We have LaKeya Griffin, who is the Interim Director of Care Management at Bay Health. And we also have with us Tiffany Fields, who is she is also a social worker at Bay Health. She's the lead social worker at Bay Health and also works part-time as a therapist. So I'm going to turn it over to LaKeya and Tiffany.
Hi, good evening, everybody. I'm going to share my screen here.
Make sure to turn on the sound.
Yep, it's on. Thank you, Tim. Good evening, everyone. Hello. Can you all see my screen okay?
Yes, we can. Thank you.
Thank you so much. So welcome. Thanks for having us. I'm LaKeya Griffin. I'm actually the social services manager here at Bay Health. I've been here at Bay Health now for almost 10 years. But also I'm the interim director of the department, the care management department here. And so we are happy to be here tonight. And then my counterpart here, Miss Tiffany Fields, is here with me as well. So I will proceed. So our presentation today, our title is Superheroes Without Capes, the Social Workers of Acute Care. And so I just want to introduce you to a different kind of superhero, one without a cape, but with a big heart, a strong mind, and a mission to help people every day. So this picture here is actually of our department, our wonderful, lovely department at both of our campuses. Our department consists of nurses and social workers. We have care management associates as well. But we are the glue that sticks together here, and we make sure that patients get home safely or to their next destination from the hospital. So as I said, I'm LaKeya Griffin. I am a proud Delawarean. I grew up here in Dover, Delaware. I'm a proud graduate of Dover High School, as well as Delaware State University, where I received my bachelor's and my master's in social work. I'm a proud Hornet, so I don't know if we have any DSU Hornet fans out here, but proud Hornet. And like I said, I have been here at Bay Health now for almost 10 years. For me, I've really grown in my role here. I started out as a social worker we have two campuses. We have a campus in Milford and we have a campus here in Dover. So I started out as a social worker here, and then I was, granted the opportunity to advance. And so I became the social services manager, which oversees all of the social workers inside of the hospital. And so I have been doing that now for almost 5 years. And then most recently, I was granted the opportunity to be over the entire department, which is very humbling for me. It's such an achievement, and I have a great team. We have a lot of great people here at Bay Health in general, but I love my team. I love my department. So thanks for having me again. So.
Hi, everyone. I'm Tiffany. I am team lead for social work. I have been here for about 10 years as well. I grew up here-ish. I moved here when I was about 9 years old. My dad was active duty in the Air Force. He retired here on a medical retirement. And then I've also lived in San Antonio and Ohio. I moved back here to Delaware in 2016 when I started working here at the hospital. I too went to Dover High School, went to Del State for about 1.5 years. Then I transferred and went to Wright State University in Ohio, and then I graduated from UNE. It was an online program. I have a passion for social work. I have a passion to help people. One of our social workers, you will hear later, she said that she's the person that people come to talk to, and that's kind of like me. So I've always liked to help people. I enjoy my job. I branched out in 2024 and I took my LCSW exam. So now I do therapy on the side as well. So I have a passion to help, but I also know that when people go through challenging times, they just sometimes just need somebody to listen. So that's why I enjoy therapy so much. So I'm glad to be here.
And even for me, the reason that I became a social worker, honestly, I wanted to be a doctor at first. I wanted to be the doctor to deliver babies, but then I realized that I'm not really a fan of blood. And so I knew that I had always a big heart and always wanted to help people. And so I, did my research and I realized that social work was what I wanted to do. And, the hospital is the perfect place. I'm still learning all of the medical terms and, in our field here at the hospital, we have to learn that medical terminology, and we, know about the different ailments that our patients have, because it helps us to better get them to where they need to be once they're ready to leave us. So it's just, I feel like I'm doing both, things that I really loved. I always loved the medical field, and now I'm a social worker in the hospital doing just that, helping people.
And it's funny, when I went to school, I went for education. And so I switched because, shout out to all the teachers, I just didn't want to be confined in the classroom. And so when I started doing my research on social work, it's so broad. You can do so many things. You can work in a hospital, you can do child protective services, you can be in a school, you can do mental health, you can be in the prison. I mean, there are just so many things that you can do. So that kind of prompted me to switch over to social work. This one right here, we're talking about our profession, us being superheroes. So one of the questions that we have for you guys is, who is your favorite superhero? I think we might have switched it's okay, did a slide. So we have some questions on here. If you guys can see this, you guys can actually pick who your favorite superhero is. I think we have Spider-Man on here. We have Black Panther. We have Storm. We have Wonder Woman, Aurora, if I'm saying that right. We have Superman, Batman, and then I can't see that
Cassandra Cain.
Or if you're not a huge superhero person, kind of like myself, you can pick a family member. So for me, my superheroes are my parents. I don't know if you guys just heard me say that my dad has MS. So when we moved here, he actually got out of the military on a medical retirement. He's my superhero because he can't walk. He always has a positive attitude. He finished school. He went and got his bachelor's, his master's, and then his PhD, and he does not complain. My mama is also my superhero because she's his caretaker. And so although they didn't know that my dad was going to be diagnosed with MS, my mom just stepped in and she helps them, and their lives have totally changed, but their attitudes are still positive. So again, it can be somebody on this list, or you can pick somebody in your family. So if you guys can take the time to just answer that question, we'd appreciate that.
And while you're doing that, for me, my favorite superhero always has been Superman. I've always loved Superman since I was a little girl. I just love, again, him always coming in and saving the day, you know, being a regular, you know, worker during the day. But then when danger hits, he, you know, change out of his clothes and, you know, go and save the world. So I feel like day to day for me, you know, for us, you know, we may look like regular, you know, people walking here in a hospital, but we save lives just as well as, you know, the doctors and the nurses do as well. You know, our profession is very important, you know, in social work. And so, you know, that's how I, you know, identify with Superman for sure, that I feel like we are the Supermen and Superwomen of the hospital.
Absolutely.
So looking at everybody, I see a lot of people chose a family member. Great, that's wonderful. And then the reasoning why is because of courage,
Nice.
integrity, attitude, compassion, strength. And you know, it's all of these are values that we have here at Bay Health. We have our mission and values, and integrity, compassion, you know, responsibility are all some of the values that we practice here at Bay Health. So it's really good to see. So thank you all for doing that. So what is acute care? So acute care is somewhere where you go when you're really sick or hurt. It's not long-term care. Acute care does not mean that you're here forever. It's urgent care to help you get stable and safe to either return home, or if there's another, you know, sometimes people need to, when they come to us, they're a little weak and they, you know, are able to walk. So we do things like get them to a rehab facility where they can go and get stronger. Another reason to come into acute care is if, for instance, if someone has a real bad asthma attack, that would be a reason to come here to the hospital. If you break your leg playing any kind of sport or any kind of limb, you break any limb, coming to the hospital would be the most appropriate setting to come to.
What is a social worker? So it's normal people, typical people like you and I, that just have a desire to help, right? I talked about not too long ago that one of my passions, or one of the things that made me want to be a social worker, is that I realized that people go through all types of things, and they just need to have people sometimes just to hear them out. So I have a background in child protective services, and we did a survey at one point, and I think they asked the clients, like, what was the most beneficial, right? Is it that the social worker actually changed your life as far as like change how your lifestyle was? Or is it that you just had somebody that was there to listen to them? And the overall consensus was, or the overall, like, you know, what everybody said was, I just had a social worker, I had that person there and they listened to me and I could tell that they cared. So their situation still might have remained the same. Maybe they still didn't have a lot of money. Maybe they still, you know, had somebody that picked on them, but just having a person that was there to kind of support them and listen to them, it changed their lives in a sense. So didn't change their situation, but it changed their lives. So that's basically what we do. We help, you know, we help patients here in the hospital. We help individuals. We help families. When people have a very tough situation and they don't know what to do, we're here, right? So sometimes, like we say that we're superheroes, we don't know what we're going to walk into sometimes when we're here working at the hospital. Or when I'm at home and I'm going online and I'm doing my therapy session, I don't know what my clients are going to tell me. But, you know, a lot of times what I do is, I'm spiritual. So I will say a prayer before I come to work. And I'll say that before I get online with my clients. And I'll just say, let me have an open mind, right? I'll ask God to give me the right words to say, because I don't know what that person is going to need, right? So as a social worker, whether or not you're spiritual or not, just know that you're that person that's going to be there to try to help that person in any way that you can. A lot of times people are going through stuff and they don't know the resources that are out there, right? And we don't always have all the answers either. So like, for an example, if I'm at work and somebody calls me and they have a question and I don't know, I might call LaKeya, right? Or I might call one of our other social workers, right? So we all kind of come together and put our resources together to try to help that client or that patient. A lot of patients here in the hospital, they have like new things that are happening to them. They might have come here to the hospital and they have like a bad tummy ache or something, and they found out from the doctor that something is going on. And so they're scared. They don't know what's going to happen, or they're waiting on testing. So it's our job when we have on here emotional superheroes, we're going in there, we're listening, we're trying to tell them that they're going to get through it. If we have to call their family members or their friends, that's what we're doing. And then also here in the hospital, we're a team. So it's a whole bunch of us. We have nurses here too. We have doctors here. We have people that are out in the community. We have family members, like I said. And so we all kind of come together and talk. So that way the patient that's here in the hospital can have the best plan before they go home.
Yes. And even just to kind of piggyback off of what you were saying, like for us, you never know how much you can change somebody's life. And I'll just give you an instance where I had a gentleman who was not making the right choices in his life. And he turned to drinking a lot. And, for us, we deal with that a lot. We have a lot of patients who may not be ready for help. And that's okay. We don't discriminate, we treat everybody the same, no matter what they're going through. And this one gentleman wanted the help. I went above and beyond, as I do for everybody. And he ended up wanting to go and get help. And he went to get help. And most recently, unfortunately, he's developed some health issues. So he's come back and he saw me in the hallway. I was walking one day, he was being transported in the bed, and he stopped and looked at me, and I will never forget his face. And he looked at me and he said, "You saved my life." I'm still feeling emotional, I'm sorry. But that just makes me do more, and encourage and empower my team to go above and beyond, because you never know, even though he's dealing with some health issues now, but he's doing well. He has a roof over his head. He's doing really good. He's dealing with his health challenges, but he no longer drinks. And that just made my day, that he still, and this was at least, I've been here almost 10 years. This was probably 8 years ago. And so just always, we go above and beyond. We don't just hand people pieces of paper and tell them to go here. We make sure that they get what they need, and in order for them to be successful out in the community and at home, and making sure that they're safe and doing well.
And real quick, the other part, I think the part that can be kind of hard is that you can't make somebody do something that they don't want to do, right? So one of the key things as a social worker is that we have to allow people to make choices for themselves, right? So it's called self-determination. So for an example, the example that LaKeya gave is, if you have a patient or a client that you're working with and they're on drugs, or they have mental health concerns, or they're drinking, and a lot of times when we roll up our sleeves, we're superheroes, we're trying to help, and we're giving this service and that service, and they're not ready. That part can be very hard, because we have to honor that they're not ready. We have family members sometimes that want us to kind of like help. And so we can only do what we can do. So if you decide to go into this profession, just remind yourselves, if you have a day like that and you're working with your client and they're not ready, to allow them to not be ready. It's okay. And if they change their mind, you're still here.
Yep. So some superpowers of a hospital social worker. So we have super listening ears and communication skills. We have comforting powers, as Tiff was just, talking about. problem solving. We solve problems all day that you can't even imagine some of the things that are brought our way, because, you know, if there's something that the doctor or nurse can't figure out, they come to us and we figure it out. We get it done. We, you know, because for us, again, being a social worker, you just have that expertise and that education to where we can figure it out. You know, we have so many resources, so many different, you know, like the social workers that we have here, they've worked in so many different areas and come with so much experience that, you know, again, we all work together. If we get stuck on something, we come as a group and we discuss our problems together to ensure that we get that patient what they need before they leave us. Bridge building, we help families connect to different resources in the community. We connect a lot of times with like community agencies like the Food Bank of Delaware, the Homeless Planning Council, because we do run into a lot of patients that do not have homes to go to. So we connect with a lot of community providers to ensure that we keep a good relationship with them too, so that when we do get those patients, that we are able to get them right to them and they'll be able to help them the best that they can. Also, a kindness ray, we spread kindness and hope everywhere we go. You know, sometimes we get people who they're in pain. They come in, they don't feel well, so they can be grumpy. They don't want to talk to us sometimes. But as I always talk to my team about, never let anybody break you down. You know, you always give them that positive vibe, that smile that they might need. Because, you know, when you don't feel good, you know, you're not always smiling and, you know, happy. So we understand that. And, you know, we just continue to give that positive vibe to our patients so that they know and always will remember us like, hey, I was at my worst when I was here, but that social worker was a ray of sunshine. Also, we're like peacemakers here. We always try to ensure and empower our patients. You know, we don't just, you know, we help them, but we also try to get them to see and get them to be empowered to want to help themselves too. We don't take all the credit, you know, like even I was telling you the story about the gentleman that I helped. I even told him that day, I was like, no, you know, that was not me. That was you. You made that choice to want to change. You made that choice to want to have a better life. I was just here to kind of hold his hand and help him along the way. That was just not my doing. And then also, again, resource radar. We connect with so many different people where we have, you know, try to get as many resources as we can for our patients, because a lot of people deal with a lot of different things. And there's a lot out here. Delaware is a small state, but there is a lot of people out here who want to help, who have started their own like organizations. And things of that nature. So we do connect with a lot of people so that we can have the most clear, detailed plan for our patients before they leave us. They're not leaving us empty-handed.
Right. So the day in life of a social worker here at the hospital. So we come in here to the hospital, we have like a room that we all kind of meet together. We get our computers, we check our emails, we check our voicemails, things of that nature. And then we go to our units, right? So we have a social worker and we have a nurse care manager. We work hand in hand, like LaKeya was saying, and we have what's called morning huddles. Morning huddles is actually with our department. So most of the time, people will leave our main office and you'll go to your unit, and that morning huddle is at 9 o'clock. That'll have LaKeya on there and all of management, and they'll give us any kind of announcements that's going on for the day. They'll give us the opportunity, if there's like a challenging case, we can talk about that then. And it usually lasts anywhere between like 5 to 10 minutes. They'll give us something like an encouraging quote before we go, just to kind of give us something positive to kind of start our day with. And more recently, they've been doing like trivia questions and things of that nature to kind of give us the opportunity. We have a point system here. So if you catch somebody doing, you know, something good, you can give them 500 points, and that equals $5. So if you win that trivia question, you get 500 points and you get $5. So that's good. After we're finished with that, then we start our day. We go and we see our patients. We have something that's called hospital rounding. Every unit pretty much here has it. It'll be the social workers, it'll be the case manager or the care manager, it'll be the doctors, it'll be the primary nurse, it'll be the pharmacy. So it's a whole bunch of people that work here in the hospital. Physical therapy, sometimes the nurse manager, and we'll talk about all of our patients on the unit. Mr. John got here what day? What's going on with Mr. John? Where is he going when it's time for him to discharge? We don't wait until it's time for Mr. John to discharge. We do it on day one. That's our goal, no later than day 2. So we want to go in there and learn about Mr. John. If I'm the social worker on that unit, I'm going in there to Mr. John. I'm introducing myself. I want to know who he lives with. I want to know, does he use any kind of equipment at home? And I want to know, what's his goal? So the plan is not for me. When patients come here to the hospital, a lot of times they're sick and they might have to go to rehab, right? But I want to know from Mr. John, where do you want to go? So we're a patient-centered hospital, right? So of course, if a patient needs to go to rehab, we're going to encourage them to go. But if Mr. John says, Tiffany, you know what? I don't want to go to rehab. I want to go home. Then it's my job as a social worker to try to say, okay, Mr. John, what family do you have at home, right? And so we want to try to set him up, for like the best case scenario. So that way, when he discharges home, he doesn't come back. Family support is listed on here. So that's what I'm talking about, where if he wants to go home, I'm calling his auntie, I'm calling his son, I'm calling his daughter. Who can help Mr. John get home because he doesn't want to go to rehab? Or I'm talking to Mr. John and I'm like, Mr. John, I know you don't want to go home, but rehab might be a good thing for you. It's just short term. If you can go for a few days to get stronger, we're trying to keep you out of the hospital. And a lot of times patients then will change their mind. And then you see discharge planning here. So as a hospital social worker, that's what our role is. We're discharge planning. And what that means is when a patient comes here to the hospital, we're coming up with a plan for that patient. So that way, when it's time for them to go home, they can be successful, right? So you have some patients that come here to the hospital and we go in there and we meet them. And I'm like, hey, Miss Sandra, how you doing? And she does not have a reason for me to see her, but she's a patient here in the hospital. I want to get to know her. And I want to know if she thinks that she needs anything. If I talk to Miss Sandra and she answers all the questions and she doesn't need anything, then that's fine. At least I went in there and I said hi and I offered. We have other patients here that we know they're going to need something. So our goal, again, is for when a patient comes here to the hospital, we try to touch every patient. Sometimes we don't, but our goal is to try to touch every patient here in the hospital. So that way, if there are some services and there are some resources that they don't know about, that we know about, we can tell them about it.
So I want to give you some examples of what we call a real life hero moment. So for example, we have a unit here that we call Women's NICU and Peds. So that is a unit where babies are born, or if babies need a little bit more care once they're, after they're born, they might go to what we call our NICU, where we have specialized nurses that take care of babies that need a little bit more time before they can be discharged from the hospital. And then we have our pediatric unit where our children under 18 would come if they did need some, hospitalization. So for example, we have sometimes moms that come in that don't have everything that they need for their baby. That's not a bad thing. Everybody is not a millionaire out here, and that's okay, right? It doesn't mean that they're a bad mom because they don't have everything that they have. So our job is, one, not to judge. We are not there thinking that they are a bad person because they don't have everything that they need for their baby. So what we do is we help that mom get whatever she needs in order to safely leave us and go home with her baby and ensure she has everything that she needs. So if there's a car seat that she might need, we get that for them, or we connect them with resources that will get them free car seats, or, discounted, or sometimes they might not have something safe for the baby to sleep in. We can help them obtain that. And then even for adults, in the adult world here, sometimes people come and they might not have clothes, they might not have food. With food, we do have a food pantry here at our hospital that one of our wonderful departments called Population Health came up with. And so if we identify that a patient needs help with food before they leave us, we do give out food boxes here at Bay Health. And then we also connect them with an additional type of support for food so that, you know, once that food box runs out that we've given them, they still have something to, you know, hold them over afterwards until they're able to get something more permanent.
This slide talks about that we can all be heroes, right? So we talked about all of the things that our team can do, and this talks about that you guys can be helpers too, right? So if you're going to be a helper, again, we talked about a lot of these things, but we have empathy on here. What does that mean? So what that means is that you need to, as you're listening to people talk, think about how another person might feel, right? So almost like stepping out of your shoes and stepping into that other person's shoes, right? As opposed to a person telling you, like, for an example, they don't have a car seat and you're looking at them like, well, you're a mom, why don't you have a car seat? Like LaKeya said, we don't judge, right? People go through different situations, you know, in their lives. And I always say, if there's a person that hasn't gone through something, keep living, because you will. So it's our job to just, you know, like I said, try to kind of like feel where that person is coming from. Be a good listener, right? So sometimes, a lot of times, we're problem solvers, right? So one of the things that I try to do now in therapy, or just in general, right? A person can come to you and they had a bad day, right? And so a lot of times, because we're social workers, we're in fix-it mode, right? So they're telling me, oh, you know, I had a hard day, blah, 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 blah. Because I'm a social worker, a lot of times it's like, okay, well, have you tried this? Have you tried that? Have you tried that? Have you tried that? Sometimes that person doesn't want you to give them a solution. They just want for you to listen. That's all they want. So one of the things that I try to do is I ask, like, what do you need from me? Do you need me to give you a solution, or do you just need me to listen, right? So allow that person to kind of like tell you what they need from you. And more times than not, sometimes people just want you to listen to them, right? And when I say listen, don't listen to respond, listen, right? So as a person is talking to you, as hard as it is, try to have a blank slate and just actually hear what they're saying, right? Helping, right? So you hear that a lot of times when you talk about social workers. As we listen, then we can kind of hear what that person may or may not need help with, right? So again, sometimes people just want you to listen to them, but sometimes people actually want you to come up and, you know, like with some kind of help, right? So if you know that they actually need you to kind of like give them resources and they need some help, then if you don't know the answer, like I said, we have a team of people, and you'll have a team of people that you can kind of call to actually get the help, right? I don't want you to ever feel like that as a social worker, you have to know it all. Because like LaKeya said, you're going to walk into some rooms sometimes and you're like, whoo, like I had no idea I was going to walk into that, right? And you just might not know. Let that person know, listen, you know, I'm here, I'll do what I can. I'm not sure what the answer is, but I'll find out. You don't have to act like you know everything, because we're human. There's no way that we would actually have to know everything. So as long as you can try to connect that person to other people and you try to find that answer, that's all you have to do. Kindness, be kind. We say all the time, like, you really have no idea what people are going through. You can have a person that comes in here and they are smiling and they're positive at all times, and they go home and it is just, it's just very challenging. People have loved ones that they have to take care of. People have medical conditions themselves that you might not know. People might not have food themselves at home. It could be an actual worker that you're working with, and you think that, oh, they have a job, they're good. They might not have a car. They might not have food at home. You just have no idea. So we always say here, just be nice, be kind. It goes a long way.
Absolutely. So if you want to be a social worker, how do you get there? So it takes definitely hard work, right? So always do good in school. You know, you want to, you know, every aspect of social work touches on every subject. So we had to learn biology, we had to learn sociology, math, all of that plays into what we do here. And so just do your best in school. If you want to be a social worker, like for instance, me, I went and I got my bachelor's and then I received my master's from the best school in the land. I'm a little biased, but it's Delaware State University. I really learned a lot in my program. When you go to school to become a social worker, we have to do what they call a practicum, which is like an internship. And so, you choose the field that you think you want to work in. So me, in the beginning, because I wanted to be a baby doctor, I'm like, I want to work with kids. So I went into what here in Delaware we call Division of Family Services. And so that agency, as some of you might know, that's an agency that helps children and families. Their goal is to keep children and families together, but when children and families can't be together, their goal is to ensure the safety of the children, right? And so you do your internship with whatever agency you choose. And then afterwards you figure out like, hey, okay. I ended up going into a job. My first job, I worked as a foster care treatment coordinator. So I helped children who were in foster care, and I helped train the foster parents to be able to work and help raise foster children. And I ensured that the foster children had what they needed. It was a very rewarding job. To be my first job, it was very tough. It really gave me thick skin because I saw things that I did not imagine was happening to children, right? And so that's one thing in social work. We do see some really, really tough situations. And does it affect us? Absolutely. It can really affect us. But again, just always ensuring that you have a good support system. You have somebody to talk to talk out your feelings, because sometimes that can be very heavy. Even in the day-to-day that we experience here in a hospital, we see people, like I said, at their worst. Unfortunately, we deal with a lot of death here. And so we have to be strong for our patients and our families and their families during that time. We help in situations like that. And so again, that's a very rewarding, aspect too, because, that's a really rough time for a lot of people. And so it's just really good to always also learn to work with people too, because, if you're not a people person, you might not want to be a social worker, because we talk to people all day long. We always are talking, and that's even for me, like, now I'm in a leadership role as a social worker. So I talk to people, I'm in meetings all day long, but me, that's the one thing that I do miss, is doing that face-to-face with the patient. I miss that. I learned so much about my patients, just having that one-on-one, but now being able to, work with more like community agencies and leaders and, the state, and sometimes even the federal government. Like, I'm working with people real high up, and it's very rewarding because I've experienced that boots on the ground work, working in the hospital as a social worker. So I can tell them the day-to-day and what our patients are struggling with and all. And so that I can be the voice for them to know, like, this is what we need on the outside of here, because this is what our patients are struggling with. And then also keeping your heart open, just always being able to help somebody. Like Tiff said, you never know, how you could be making somebody's day. Even just a simple hello to them, just checking in, or a call, keeping them informed. We're not doctors, we're not nurses, so we don't really give more of the medical aspect of things to the patients and families, but we help them deal with any bad news, good news that they might get in reference to their medical history or why they're here. But just always keeping your heart open, always wanted to be able to help and just make sure that you change somebody's life if you can, even if it's small. So this slide here, these are 4 of our wonderful social workers that we have here at Bay Health. And so I just wanted to share with you their perspective and why they wanted to become a social worker.
So why did I become a social worker? I'd have to say that when I was in high school, I was the person everybody came to when they had problems, and I was always good at solving problems. People came to me for advice, and I guess I always felt like I was helping people with good advice and problem solving, and that's why I became a social worker.
Hello, I'm Marisha. I'm a social worker here at Bay Health. The reason why I chose to be a social worker is to be an advocate for patients or people who are too scared to speak up for themselves, or for anybody who doesn't have a voice to use. So that's why I became a social worker.
I became a social worker because when my stepdad was retiring from the military, he had just come off of a deployment and he was struggling adjusting to civilian life, and he had a social worker at the VA that was very helpful, made a huge impact not only for him but for us as a family to adjust to our new norm. And I wanted to make the same impact in the world that this social worker made for me and my family, and so here I am.
I chose to be a social worker because I enjoy helping others. I enjoy helping them navigate difficult situations when they may not know what to do. Just being an emotional support, advocating, making them aware of what services and resources are available to them, being a part of an interdisciplinary team where we all come together and discuss the needs of the patient, and I help to put those services in place, making sure that the patient has a safe discharge plan and that the family feels supported in caring for their loved one. I've been a social worker for about 13 years, 2 of which have been in a hospital setting. It's so very rewarding, and I cannot see myself doing anything else.
So as you can hear, just, out of these 4 ladies, they just have different reasons, but the same message is that they want to be able to help people at all times, even Arisha, for her patients, being an advocate for her patients. That is a big thing that we do here in the hospital, because some patients don't have anybody. Mm-hmm. We have a lot of patients who come in that, may have had family situations to where they might not have spoken to a brother or sister or their son or daughter in years for whatever reason, and they don't have anybody. And we are their voice. A lot of times we are helping them navigate through, and it's a lot of things out in the community that, people don't understand or, know about. And it's our job to find out what that is, what will be able to help that patient, and then speak up for them if they're unable to do so. That's a big thing for us here, for sure. But these 4 wonderful ladies have been such an asset to this organization. Mm-hmm. And the years of experience range from 20 plus all the way down to, I think, maybe 5. I feel like Arisha's been here about 5 years, but all of them bring something new, something different to the team, and they all go above and beyond. Everybody goes above and beyond here, just at Bay Health in general. And, so I just wanted to share, their reasoning on why they became a social worker. Mm-hmm. All right, so any questions, comments, or concerns?
Okay, hold on for a second. If you could stop sharing.
Sure.
All righty. So, there's some professional and ethical things that come up in social work. Duty to report, self-harm, suicidal ideation. Can you talk about those, and then also what's the path to manage and know what, from a practice standpoint and from an ethical standpoint, is the right thing to do?
So for us here at the hospital, doctors, nurses, social workers, we are all mandated reporters. So if a patient comes in and lets us know that they've been harmed or they've harmed someone else, we are mandated to call and report that. Now, that doesn't mean that we stop helping them, you know, with whatever their needs are. You know, they're still our patient, but if they tell us anything to where we know that they're going to harm anyone or they've been harmed, we do report that. And then we become the, I guess you would say, the bridge between the reporting agency that we report to and the patient, and ensuring, again, a safe discharge for our patient, as well as anyone that might be affected by whatever they reported to us. So we do get that a lot here at the hospital. We deal with a lot of elderly patients who, you know, has family that are caring for them. And, you know, being somebody's caretaker can be very challenging, you know, and, you know, that's one thing we do a lot, is give a lot of support to the families, resources that they can utilize, because taking care of somebody can be very hard and it can be very stressful. And so we definitely identify that when we have, you know, situations like that. But again, you know, if that patient's been harmed in any way or it's been reported to us, we do have to report it. You know, sometimes we get confused elderly patients where they're so confused because they might have a disease like dementia or Alzheimer's, to where they might think they're being harmed, or sometimes we get, oh, they're taking all of our money. You know, we get that a lot. And really, reality, you know, even though they're telling us that, we don't know if this is true or not. We still have to call and report it. And then, you know, we kind of help follow up from there to ensure, okay, was this the truth or not, to ensure that they're going back to a safe environment.
Right. Well, and I think I could successfully argue that nurses, social workers, and primary care providers are often treating the family as much as they're treating the
Oh,
patient.
absolutely. And that's a big thing for us here. You know, the patient is our patient for sure, but we definitely include that patient's what we call caretaker or care partner is what we call it, because they are a big piece of that patient's care, you know, and we need to, you know, because a lot of times, you know, I give you scenarios, we get older patients who, you know, daughters or sons, very protective over them, as I would be with my own mother or father, right? But the mom, you know, they can still make their own decisions, and they don't want their daughter or son telling them what to do. So we deal with that a lot. You know, just kind of, you know, bridging that gap and making them understand, like, hey, your daughter or son is here to help you, you know, and this is what, you know, why, and, you know, and to get them to understand that they're just not trying to tell you what to do. They're just trying to make sure that you're getting the best care and, you know, are going to, you know, leave out of here and be successful back at home. So.
Yep, absolutely. Interesting too, you said care partner, and there's a caregiver.
Yes.
And they're caretakers, and that's completely different. A caretaker on the death end of things. That's a caretaker.
Right.
So yeah, we generally don't refer to anyone in the clinical setting as a caretaker.
Right.
Anyway, but I digress. So this is a general question and a specific question to Bay Health. It looks like your team is all women. Do you have any idea? Are there any male social workers at Bay Health? And then more nationally, do you have any idea what the stats are on the ratio of men to women?
I don't know any stats, but here at Bay Health, we do have male social workers. We have two actually. We have one who's been here for almost 20 years. And I will say he taught me what I know.
Me too.
He's been here a long time, very well known, is, very resourceful, a huge advocate for his patients. And even our other social worker, he works with us. He was full-time, but now he, is per diem or part-time for us. But still, he's ventured off into a world where he's helping children, so he gets the best of both worlds. But full of knowledge, I do get a lot of interest, which we, didn't have any openings, but I do get a lot of, resumes of male social workers, and they're definitely needed for sure. But yes, we do have a male social workers as well as male nurses here. Yeah, we sure do.
Right. All righty. So let's talk about discharge planning for a minute. So a couple of things. First off, the simple question of how fast do you discharge your patients? But if you say you want to create their discharge plan, you want to see them within 2 days.
Right.
But what if it's a really quick turnaround? Are there prescribed discharge plans that you can tap for a fairly typical situation, or do you just have to like pedal to the metal and create that plan with as much information as you have available if you haven't seen them personally?
So we will see them, but I don't know if you remember me talking about us doing rounding on the units. So that's very helpful. So in the morning times we do that. If there's a patient that just came that day and the doctor is there, they will let us know. And if they're not in rounds, they will find us and they will say, Miss Annie is ready for discharge. So we are still seeing them on day one if they're ready the same day. So as soon as we can get in there, we're trying to go in there and meet that patient, and get them out the door.
Right. The other thing about discharge, you dropped a term that I know the definition of, but I just wanted to go back to it. You used the term safe discharge planning.
Yeah.
What does that actually encompass for those people who might not know what all that is?
So a safe discharge plan means that when they leave us, one, they are in their right state of mind. If they are not in their right state of mind, if we have someone who might be confused due to whatever ailments that they might have, we ensure that they have support, someone to watch after them when they leave us. We ensure that they have housing when they leave us. Food, we check for what we call SDOH, which is social determinants of health. We screen, nursing screens, as well as we screen to ensure that they have what they need before they leave us. And so we ensure from the doctor, the nurse to our department, we ensure that that patient is leaving us and has all that they need after they discharge from us.
Right.
Now, on the flip side, we have patients sometimes that are alert and oriented times for the way that we are, right? And we work with them to try to provide that safe discharge plan, but they don't want it, right? So then we kind of circle back to their right to make their own choices, right? So if they decide that they don't want the resources, or they're homeless and they decide that they don't want to go to a shelter and they prefer to live on the street, it's up to the doctor and up to that patient, right? Because people are allowed to make poor choices if they're in their right state of mind.
Yeah. And the most important too is making sure that medically, they are stable for discharge. And the doctor definitely notifies us of that, as well as the patient. So we make sure that the reason that they came in here, which some of the reasons I gave earlier, the broken leg, the asthma attack, we make sure that one, they're breathing, they have medicine that they might need to ensure that they continue to not have an asthma attack, or they've received a splint for their broken leg and it's stable, they can walk. We ensure that they can get into their home. That's something else we look at. We ask a question now to our patients, do you have keys to get into your home when you leave us? Because sometimes patients don't have cars to get home, so we can, provide transportation, but it's not, appropriate if we set up transportation and they don't have keys to get into their house. That's not safe. So we ensure that they have keys to get in. If they don't, we figure out how to get into their house.
Right. Okay. How's the work-life balance?
Good question. For me, I preach this to my team too. You have to take care of yourself. And as I said earlier, we deal with a lot of heavy situations, and me, I'm a little emo person. So I get, emotional sometimes, but that's just the empathy in me too, because I always try to put myself in that person's shoes. So for me, when I leave here, I take care of me. I have a family at home that I need to take care of too, right? And so just taking care of yourself and knowing that you did everything that you can, right? Like sometimes you can do everything and, it may not seem like even that patient or family is grateful for what you've done, but just know that you tried your best and you do the best job that you can. And, I just leave it all here. When I come back tomorrow, I start again and I'll put my Superman suit on and I'm ready to go.
That's it. That's it.
Or Superwoman.
Yes.
Or
Yes.
Batman.
Right.
Yeah,
Right.
Right. So what other activities do you or social workers in general use to help patients cope with what they're going through? So I think the emphasis here is on the coping resilience side of the equation.
So we link them to resources. So for an example, if there is a patient that comes here to the hospital and they're lonely, right? They're an elderly person, we will link them to like Modern Maturity Center here is what we have. It's like an elderly community center, right? So that way they can kind of link with other people their age and make friends. If you have somebody that maybe they lost a loved one and they're having a hard time coping, mental health resources, right? So we'll link them with like counseling, like counseling services that are here. It just depends on what they're going through, right? So I think a lot of it is that they need the resources and referrals. Let's say, for an example, there's a caregiver and they're having a rough time. We have something here called Easter Seals, right? So it provides all kinds of resources. Respite for the caregiver, they can be a paid caregiver. So we're basically just giving them resources and referrals to help them cope, if that makes sense.
And even here, while in-house, sometimes you have a lot of patients who, again, are getting some heavy news. They might have received, unfortunately, a new diagnosis of having cancer.
Right.
We have a really great cancer center here, but also we have a great pastoral care department here. So if we know after speaking to a patient, and they're spiritually based, we can have our pastoral care to come in and speak to our patients to kind of help them get through that rough patch, along with us, checking in with them and being, a source of support as well. But that's another, thing that we could do here in the hospital while they're currently here.
And pet therapy too. We have that here.
Yeah, I forgot about
that. Yeah, we have animals here on the scene. We have dogs and they will go around and see the patients.
Yep.
Right. Well, it's that integration too of occupational therapy, physical therapy. Sometimes, in my experience, patients might admit to needing something to social work that they wouldn't to the clinical side.
Absolutely.
Yeah, I mean, often I think there's this sense that with clinicians, especially with physicians and physician assistants and NPs, if I tell them this, then it's going to be another drug, another procedure, and that's not always the case.
Right.
That, and increasingly, especially in terms of medication intervention, that's definitely not what we want to be.
Right.
Is adding one more medicine to their pharmacopoeia. I dropped into the chat, not to have you all speak with it anymore, but sometimes people hear about competency and capacity. I dropped a little definition into the chat. One of them is determined by the legal sector, the other one's by the clinical sector. They're both important, and I'm sure you all deal with both competency and capacity on a daily basis. So a final question. So Delaware licenses bachelors in social work, clinical social workers, and licensed master's social workers.
Yes.
So what's the difference, the hierarchy?
Okay. So licensed master social workers, that's our professional license, right? And so we are required to have so many, we have to do what we call CEUs, where we have to do training throughout the years. And we have to have so much to pretty much stay on top of our education in our field. And so that is a requirement now in Delaware. So if you are wanting to be a social worker, you do have to be either a licensed bachelor social worker or a licensed master social worker. Here at Bay Health, the requirement is for you to have a master's level degree. But the clinical social worker, and I'll let my newly licensed clinical social worker here to my left explain that role to you.
So we too have to have CEUs, and that's our continuing education units or credits. We have to have 45, and it's every 2 years. To be clinical, you have to actually complete like your clinical training in a clinical setting and have like a supervisor that's an LCSW supervise you. And you have to do that over a 2-year period, and you have to have 32 plus hours, 3,200 plus hours to be able to get that. And then once you get that, then you have to sit for a test that lasts for about 4 hours. They give you, and it's 180 questions. And it's brutal.
Yes.
And then once you pass that, then you're a licensed clinical social worker, and you just have to keep doing your CEUs every 2 years.
And the difference with the clinical social worker is, so for instance, in our roles, it's not a requirement, it's a plus if we have it, but we do have licensed clinical social workers that deal with our patients that have mental health issues. That come in with a crisis, a mental health crisis. That individual can assess the patient to determine if they need more severe, more psychiatric care. So they can, recommend that the patient need to go to an inpatient psychiatric hospital. They could diagnose a patient. So if you have someone that's dealing with depression, anxiety, they could, diagnose them with that, and then also prescribe under the supervision of a psychiatrist. So they do have the capability of, clinically diagnosing a patient.
And in the outside world, I'm sorry, Tim, if you wanted to actually have your own practice, you could do that. So LMSW, you can still have your own practice. You just have to go under an LCSW. LCSW, if you want to have your own practice, you can. And then you can also be the person that an LMSW gets their hours from, but you have to have your LCSW for at least 2 years.
And they provide therapy services, to patients. So those patients that need, a therapist, they are the ones that they could go to and talk to and work out their problems or issues with that licensed clinical social worker or the licensed master social worker. There's a ton of areas that you could work in as a social worker. So, just never, my one takeaway from it is never just put yourself into one little bubble, right? Because I never imagined that I would be a director over a department in a hospital as a social worker. My goal always is just to help people, right? But to see myself in this role, it's like the sky is the limit for me, right? And I love the hospital. I do, and I want it wherever I'm going, I want to go straight to the top. I'm not trying to take anybody's job, but I would love to be the CEO, right? So, but hey, I want to go to the top, and I want to show that us as social workers, we can do anything you could put your mind to. You can work in any area. I mean, there's social workers that are senators in the state of Delaware. Sure. I don't know if you all know Senator Marie Pinckney, but she is a licensed clinical social worker. And, you know, we've had her come and speak to our department, you know, during Social Work Month, which is in March, by the way. But I wanted her to come because I wanted my team to see that you could do anything. Like, she is making laws in Delaware as a social worker. So that is just amazing. So please never limit yourself to, you know, because I know everybody, you know, you say, oh, it's a social worker. The first thing you think is, oh, they're just coming to take your kids.
Exactly.
That's the first thing people always used to think, oh, you just take somebody. And it's not that. Even the Division of Family Services, that is not their goal.
It's not.
Their goal is not to take children away from families. Their goal is to reunify them together and help them stay together. So even if you want to go into that area, that's awesome. Like, do that. You know, be that advocate for that mom that might be struggling to be a mom, and you know, be an advocate for her child as well. So never limit yourself. Go to the top and come on.
Come
social
join
work.
us.
Let's go. Come to us.
Yeah, well, and you mentioned about the maintenance of license and recertification and whatnot, that continual education is part of the game, not just for social work, but across our profession. We're constantly learning.
Yes.
And for those of us who, you know, are really into our jobs, that's not even a burden. That's another part of what makes it so cool, is we're constantly learning. And I think that one of the reasons that we have a lot of adult learners who continue in mini medical school, even though this is really for students, is because they too want to keep learning. So Natalie asked a great question, and I'm going to answer it so everyone can hear who's still on. When do you get your certifications? So those come via email. Nicole Sabine is still out of the country. I thought she was gone for 1 week. She's gone for 2 weeks. She was visiting family in Poland and Eastern Europe, so she's having a great time. Anyway, it's usually about a month after the series wraps up that the certificates are issued, just to tell everybody that now. A final question, and this is kind of a big one, but we'll go out on a high note. There are the 5 wishes. There are advanced directives. There's the Delaware medical orders for scope of treatment. Have at it. Compare and contrast. Where do you touch those? Where are you involved in those different levels of documentation for what people want for themselves, or what a clinician does shared decision making with them?
So for every patient that comes in, our department actually does an assessment where we ask, does that patient have, you know, if they were ever unable to make decisions for themselves, do they have someone that they would want to make decisions for them? And if so, do they have the formal document, which is either a power of attorney or an advanced healthcare directive, which actually is something that goes over what that patient would want medically if they were ever ill to where they were unable to make decisions for themselves. What would they want if they unfortunately had a stroke and couldn't talk? Would they want, you know, some patients, you know, want everything done. You know, some patients want the doctors to do everything that they can. So for us, when we identify that a patient does not have either of those documents, we give them the information on how to obtain those. If it's, you know, more severe in nature and, you know, they are dealing with something that, you know, medically complex, we connect with our palliative. We have a palliative care team here at Bay Health that can help that patient and guide them on, you know, their disease. If they've been, like I said, newly diagnosed with cancer, you know, help them understand that process. So we connect them with that, or the physician, the doctor will connect them with palliative care. And we just kind of collaboratively work with palliative to provide that support for that patient and that family, and ensure that they have their affairs in order, you know, before they leave us.
Right. All righty. Well, what a great end to a fantastic series. Thank you to both of you. And by the way, we heard from your colleagues on the palliative care team
Oh,
a couple of weeks ago. So
nice.
that was perfect. I want to remind everybody that the PowerPoint will be turned into a PDF, so you won't be able to watch the video clips again. However, for those of you who are here, you'll know what was going on, and the recording will go up probably in 24 hours. And the next mini med series starts on November the 5th. So come in, the water's warm. Thank you to the two of you. Thank you to everyone at Bay Health. We appreciate you. Have a great Halloween. Take care.
Thanks for having us.
Bye-bye.
Bye.